I was just reading the news before. Sorry, I wasn't listening to you talk. No, I was listening to you talk, Michael. But I was just in a gripping news item here. French chef sues Michelin over lost star, citing cheddar error. I think it's just very important we get things in perspective here tonight. So there are more important things in the world than, and often it takes a diagnosis like this to sort of bring it to the forefront, and we often worry about things that aren't that important. So my talk will complement Michael's. I don't have many slides, so I just like to chat a bit about things. So this is a common disease. This is Australia's disease, melanoma. We have the dubious honour of having virtually the most cases in the world, bar maybe Hawaii or New Zealand in some centres. But the thing about melanoma is it unfairly affects young people more so than many other cancers. And the sad thing about that is that, having a serious diagnosis, particularly in a young person, is a very, very traumatic thing, and the amount of life years lost. Not to, if you're over that age, don't feel like I'm not thinking about you too. But it's the third most common cancer overall, I believe, in males and females. It's so. Is that right, John? I think that's about right, isn't it? It's about third. It's certainly a very common cancer overall, and has a huge strain on the patients themselves and the health system. And there's a variety of reasons for that strain, which I'll go into. But the most cost-effective way of dealing with this is through prevention. And $1 spent on prevention is still much more cost-effective than $1 spent on trying to save someone with advanced stage 4 disease. And we do, I think in Australia, our programs are actually very good compared to a lot of the world. We do spend a bit on prevention. We could spend more in education, but we certainly lead the world. When we have internationals come over and look at our programs, they're awestruck by the degree of education that we try to provide with patients. So I think in that sense, we're very lucky. So the treatment, so you got prevention and early treatment and then late treatments. There's sort of three different stages where we like to think, and they have different sort of impacts on patients and costs. So just to highlight that, these figures were actually derived from paper, but they're a little bit woolly. But a stage 0, a very early melanoma, level that hasn't advanced, very easy to treat. Cut it out, patient's cured. That's it. If you get it early enough, it's cured, not a problem. But if you've got stage 4, that's the most advanced melanoma where it's spread maybe to the liver or to lungs or something like that. That's an expensive thing. But money's one thing. The actual impact on patients themselves, their families, their ability to live their life or provide, earn a living, is severely impacted once you go up that staging scale. But early melanoma, certainly if we can get it early. As Michael said, the incidence of melanoma, invasive melanoma, is decreasing. The paper I did shows that the incidence of what we call level 1 melanoma, or situ melanoma, that is actually going up dramatically. So there's good and bad, I suppose, about that. The fact is we're getting them early. But we've still got it's a very common and costly issue. Now, when we have a look at, say, the cost of treating a melanoma in its early phase, it may say, oh, that's pretty cheap. But the trouble is, for every melanoma removed, there's a big range of benign lesions removed, which adds a huge impact on the patients and costs to the community. So if you go into some groups are removing, will take off 1 melanoma for every 30 benign lesions. So imagine that the huge cost on the health system, and this is why we need improved ability to diagnose these lesions. You can't have a dermatologist on every corner. We're generally much better at diagnosing them, but we're a finite resource. So we need to improve access for patients to either people with better skill sets or artificial intelligence which we'll chat briefly about, but that's the way the future is going. And just want to touch on something, people sort of get this mindset. I remember once I had a patient whose husband had died of melanoma, and she brought her daughters in to see me, and she wanted every one of their moles cut out. Now, that's not an uncommon reaction, that she's worried, but that's not going to do them any good, because they're all benign. They would have caused physical and psychological scarring through unnecessary procedures. And also, people get fatigue about coming back and having procedures all the time. And if suddenly you just keep cutting off every benign lesion, eventually they'll get sick of it, and maybe they won't come back when they need to. So we don't like this approach of let's just cut off everything we see. You need to have a very balanced, scientifically clinical approach to patients, and not do too many unnecessary procedures. And the government does actually look at these costs when we talk about trying to treat, say, advanced stage 4 melanoma. Grant may even talk about that. But so with the other condition I specialise in, skin lymphoma, one of the treatments we have for it costs, well, we only do trials on it at the moment, costs $250,000 per 6 cycles of treatment. That's way outside the government's sort of guidelines for what they'll allow us to spend or what they'll approve. So all these, the government does actually look at the cost effectiveness of all these treatments, and they're very interested in making sure that we have a very efficient health system. This describes how we divide up money in the health system. We put a whole lot of sharks without any food in a tank. Health money is a finite resource, and we'd like to think it's ever expanding, but it isn't. So if you have people doing unnecessary work, say unnecessary excisions, they are taking money away from something that can be really useful. Because there's a lot of, say, procedures done out there, not say in orthopaedics and such, which provide absolutely no benefit to the patient whatsoever, but are still being undertaken. And this all eats into what is available for the government to spend on patients. In our own hospital, if we have a patient who comes from overseas and is not on Medicare, we can't just spend the money on the drug. We have to go and ask for compassion access either by the hospital or the drug company, because there just isn't an endless well of money for these things. So I like to emphasise that it's very important that at a grassroots level in the general practice that everything, that things are done efficiently, mainly for the patient's point of view, but also from an overall population point of view. So people will say, why don't we just screen everyone? Get everyone checked every year. Well, it's not been proven to be cost effective to do that. We don't have the amount of doctors who with an adequate skill set to do that. So what we need is more targeted sort of screening and checking of higher risk groups so that we can pick up most melanomas hopefully earlier. And certainly a lot of work's been done by many groups around the world on this. And so people with higher mole counts, previous melanomas or family history, they're the ones who'll benefit from having regular checks. A lot of us who work in dermatology have a lot of patients come and see us who have actually relatively low risk. And this is one of the side effects of having very effective campaigns warning against skin cancer, is you get a lot of people who want to come and see a specialist because they're worried about skin cancer, even when their risk is very low. And so we're a bit out of balance with that at the moment. I probably see too many people who don't really have enough risk factors to really warrant to come and see me. But anyway, at least when they see me, they're less likely to get an unnecessary excision. So the future, I think, will be how artificial intelligence actually is melded into all medical practice. And there's certainly various programs around here to help doctors diagnose, and certainly in my basic, relatively basic computer program at work, with medical program. It helps pick up drug interactions. Very simple thing. And you may say, oh, is that important? Well, drug iatrogenic or doctor-induced admissions to hospital make up probably 7 to 10% of admissions, which is another huge impact on the health system. And so all these things, if we can keep improving on our efficiency, then we can target the people who really need healthcare, which is so. As Michael was emphasising before, one of the things that doctors can be prone to doing, particularly with melanoma, is over-investigating. So someone will have a level 1 melanoma or a very thin melanoma where the risk is very low, and they'll go and order CAT scans and MRIs and things like that, thinking they're doing the right thing, with virtually close on 0% chance of picking anything up. Although that may give some temporary reassurance, it's really the wrong thing to do, because it doesn't. We just know that there's no point in doing those sort of investigations in the absence of any specific symptoms that suggest you should. We'll just get on to a bit in terms of melanoma risk factors. Most of the time you can't actually, there's controllable and non-controllable. So that's how I like to think about it. You can control, even if you've had a melanoma, you can still control the amount of sun you get. And I don't want, people say, they don't want to go in the sun at all. You need some sun. You got to live your life, enjoy your life. And the main thing I advise people is don't get burnt. You can follow those apps or just sun smart type behaviour through the sunny months of the year, but avoid getting burnt next to the sun. So even as if you're in 40s, 50s, 60s, or whatever age, I still believe in being sun smart, and certainly it's very important in that young adult group, as Michael indicated. Because it's basically if you get exposure at 20, the lag time may be 20 or 30 years. So it's very important in those early years to prevent excess sun exposure, sunburning in particular. So other controllable things are self-checking. Now I think it's easy to check, often with the aid of photographs that you may have had done. I still use, patients get A4 photographs done by professional clinical photographers, or there's various centres. Most of the public hospitals have these at a reasonable cost. And just checking against an old photo is very useful. Reassuring, that one hasn't changed, or that's changed, I better go get that checked out. And you don't depending on your risk, you don't necessarily have to do it that often, maybe every couple of months or every 3 months. Something maybe every 6 months. And then if you need to go to your doctor every year or so, you're helping yourself by checking. Because people often come to me and say, I do a skin check and say, you've got no skin cancer, and they say, I'm right for the next year. And I say, no, you're right for the last year. You're not right for the next year. So I say, you may get a melanoma the minute you walk out the door. And I said, how should I be safe, doctor? And I said, I'll see you tomorrow. So I don't know. You've got to take responsibility for your own care and check yourself, or get you a friend, a partner, go down the bus stop. I don't mind, wherever you want to go. And then control all medical professional checking. One thing I say, GPs are very good. They have to know a lot about everything. Don't go to your GP and on the end of a consult say, while I'm here, can I check your skin? Because that's putting them under too much time pressure. You go there specifically, what are you here for? I'm here for a skin check, nothing else. And that way they can do it properly. A skin check, to do it properly, you've got to get fully undressed in good lighting and look all over. You can't just lift up the back of the shirt and say, oh yeah, you're looking pretty good. So that's the most important thing I can say is just go there for that reason. And if they're given time, most of them do actually have the skill sets to do it properly. A very smart lecturer when I was in university said, most mistakes are made by not looking rather than not knowing. And that is true of skin as well as anything. Doctor needs to take a proper history, do a proper examination, form a plan. No point, you can't just look at a lesion and say, oh yeah, that needs to come off. Well, sometimes you can, but most of the time you can't. You've got to take history, what's happened with that lesion. History is very important as well. Check the qualifications of your doctor. I mean, if they're promoting themselves as a skin specialist, there are some very good skin cancer clinics out there, but there are some who have done a weekend course. But there are some very good skin cancer clinics. I recommend going through your family GP is usually the most effective. And then just go over to the non-controllable for the minute. Genetics. People often come and say, oh, is my melanoma genetic? Well, I'll put it this way. Think about hair colour. Hair colour is simple genetics. You know, sort of brown and black are dominant sort of colours. If you've got blonde hair, or you marry someone with brown hair, you're more likely to someone with brown hair as a child. So they're simple genetics, what we call high penetrant genes, where it's relatively easy to map. There are some high penetrance genes in melanoma, but they're pretty rare, and they run in families. So if you've got 3 or more first-degree relatives with melanoma, then we'd start thinking, oh, geez, do we need to get some genetic assessment here? But if you've just had one melanoma, we've got to think, what's the risk of one melanoma in a person? Well, in men, 1 in 20 over a lifetime. In women, 1 in 25 over a lifetime. So it's pretty common that you'll have someone in your family or your cousin or something who's had a melanoma without it necessarily being a high penetrance genetic problem that you need to go and check. Most of the genetics are low penetrance things, nevi count, skin colour, things like that. It's more environmental factors plus the genes. And immune status is in both because there are sometimes people are on drugs that, say for rheumatoid arthritis or something, they can sometimes, if someone's got a melanoma spread, we may want to try and modulate that. And I'll just briefly mention this. It's not Star Trek, but this is a new Vectra photography machine. And this combined with artificial intelligence will hopefully be the way we do a lot of mole mapping in the future. This has about 120 odd cameras in it and does quick shots, really quick, a couple of minutes you're in and out. And we hope people go in that, have their shots, identify any risk factors, and then they may come back in 6 months, have more shots. Well, of course, the first time there's any significant ones, they'll get those assessed, and then 6 months later or whenever, have some more shots in the machine. We'll be able to see if there's change. So this sort of technology will be coming in the future, and as artificial intelligence gets better and there's more deep learning in these algorithms we develop, these sort of things will help make it more accessible to patients, particularly regionally based patients where they may not have access to specialist care. So yeah, what will happen is they'll take a photo, and some people have hundreds of moles, and you'll be able to click down the image, enlarge it. It's really quite it's going to be quite sophisticated software, and then combined with doing dermatoscopic imaging, which is very magnified imaging, we'll be able to monitor people a lot more effectively. And I think this will be an adjunct. It won't replace a good medical assessment, but it'll be adjunctive and help improve overall diagnostic rates, I think.
Okay, thanks, Chris.